Hello, my name is Katherine Parkers, and I'm a freshman nursing student at the University of Michigan. I'm going to present a patient to you. Patient is a 19-year-old Caucasian female. Her marital status is single, and her current occupation is student at the University of Michigan. She primarily receives her health care from the University Health Services on campus of the University of Michigan. The patient's chief complaint is pain in both knees. History of present illness. Patient first experienced knee pain in May of 2013 when she tore her left ACL while playing soccer. An MRI was taken to reveal a complete tear. Patient had a full ACL reconstruction in June of 2013. She attended therapy for 4 months post-surgery. Patient then returned to full activity level. In April of 2014, patient tore her right ACL while playing soccer. Once again, an MRI revealed a full tear. Patient had a full ACL reconstruction done on her right knee in April of 2014. She completed 4 additional months of physical therapy. In December of 2014, an arthroscopic surgery was completed on the right knee to remove scar tissue causing decreased range of movement. Although both knee reconstructions were said to be effective, patient complains of throbbing knee pain. This pain is localized behind the kneecap. Patient reports that pain is constant and intensifies with exercise or activity. Patient rates the pain at a 5 on a scale from 1 to 10 when pain is at its worst. To reduce pain, patient stated that she rests, reduces pressure on the knees, and takes ibuprofen at a dosage of 800 milligrams or more. Patient admits that she is not able to do everything that she would like to do due to the pain in her knees, but the pain does not have a large effect on her activities of daily life. Since she is experiencing so many problems with her knees now, she only perceives the problem getting worse as she ages. Vitals. Patient's vitals are stable. Patient's blood pressure is 112/64. Patient's pulse is 78. Patient was sitting and resting before pulse was taken. Patient's temperature is 98.9 degrees taken orally. Patient's respiratory rate is 16 breaths per minute. Patient reports to be in no pain when resting. Health history. Patient had no serious childhood illnesses. In 2014, patient was diagnosed with seasonal affective disorder and a mild general anxiety disorder. Patient uses light therapy to help with her seasonal affective disorder. Patient reports not to have had a panic attack in over 2 years. In 2015, patient developed meningitis. She was put on antibiotics and took about a week off from school. Since having meningitis, the patient states she has had headaches and migraines, but they have decreased in frequency over time. In 2016, patient was diagnosed with exercise-induced asthma. Patient complains of tightness in chest and throat when completing strenuous exercise. She states she has never had an asthma attack. Immunizations. Patient is up to date on all immunizations. She received a flu vaccine in 2016 in October. She received her last tetanus booster in May of 2016. Allergies. Patient has no known allergies. She has never had a drug reaction in the past that she is known of. Hospitalizations and surgeries. Besides the 2 ACL reconstructions and the right knee scope previously mentioned, patient has had no additional surgeries. All 3 knee surgeries were done outpatient, so the patient was able to return home the same day. Patient has never been hospitalized. Current medications. Patient is currently on 3 medications. Patient takes an albuterol inhaler twice before strenuous exercise and additionally as necessary to control asthma. Patient takes 50 milligrams of Zoloft once daily for anxiety. Patient takes 1 milligram 20 micrograms oral contraceptive combination birth control pill every night around 10 p.m. Health habits. Patient drinks alcohol socially 2 to 3 times a week. When patient drinks, she usually drinks 6 or more drinks in an evening. Patient uses no illicit drugs. Patient uses an electronic cigarette daily several times a day. Patient was a former athlete and now exercises 2 to 4 times a month. Patient complains that high-impact exercise, such as running, puts a lot of stress on her knees. When patient exercises, she does so at the campus gym. Patient states that she usually gets between 7 and 9 hours of sleep a night. She takes afternoon naps daily and states that she usually feels tired during the day. Patient states that she has tried to maintain a nutritious diet and primarily eats in the dining halls at her school. Patient's caffeine intake varies per day from 0 to 4 cups of coffee. Patient reports to using her seatbelt approximately 50% of the time when riding in a vehicle. She admits to texting and driving frequently. Psychosocial data. Patient formerly lived with her mother and her mother's boyfriend in Michigan. She lived with her 2 younger siblings as well. Patient's father lives in another state and is not involved in her life. Patient generally gets along well with her family at home. Now she is currently living in a dorm at the University of Michigan. She shares her room with a roommate. Patient reports having a large friend group, a best friend, and a boyfriend of 2 months. Patient cites school as the main source of stress in her life. To deal with stress, patient states that she naps and uses light therapy. She is working to achieve her bachelor's degree in neuroscience with the goal of attending medical school in the future. Patient reports that she is agnostic and does not practice any religious practices. Patient regularly visits urgent care at the University Health Services with her health concerns, stating that a long wait to get an appointment is the main factor in doing so. Patient says that she feels safe where she is living and is not a threat to herself or others. Family history. Patient states that she has had a family history of thyroid problems on her mother's side with both her mother and her maternal grandmother. She was not able to provide more information. Her maternal grandfather was diagnosed with Alzheimer's recently. Both maternal grandparents are alive, as well as her mother. Her father is also alive, but not much is known about his family health history. Due to my patient's history of knee surgeries and trauma, it is essential to assess her musculoskeletal function, essentially with her lower extremities. Additionally, with having had meningitis in the past, as with most central nervous system conditions, it can have an effect on the function of the spine and neck. Due to these two factors, I will be conducting a thorough musculoskeletal assessment. Review of systems. Patient reports some pain, swelling, and stiffness in both knees. She also reports stiffness in her neck. She states that she has not had muscle weakness or pain and no bone pain, deformities, or trauma. She does not have any muscle disorders, nor does she have any family history. She is not limited in any typical activities of daily life, but she states she is not able to run more than 100 yards without severe pain. She does not use any mobility aids. She reports no recent weight gain. Her job in the dining hall sometimes requires lifting of a maximum of 20 pounds. Physical assessment. Patient had an erect posture and even gait. Patient's muscles and bones appear symmetric in size and shape bilaterally. Patient's spine is midline, and cervical, thoracic, and lumbar curves are present but not exaggerated. Patient's iliac crest, scapula, and gluteal folds are all level bilaterally. There is no signs of scoliosis. Patient's extremities are equal in length. Patient has active and complete range of motion in all joints. Patient's muscle strength was graded a 5 in all muscles. Muscle strength was equal bilaterally for all tested muscles. Movement was smooth and symmetric. There was no pain, inflammation, redness, or warmth at any joints except for the knees. At the knees, there was slight inflammation inferior to the kneecaps, symmetric bilaterally. There was no pain or redness when seated in a resting position, but when patient fully flexed, mild pain occurred and was rated a 2 out of 10 in both knees. Crepitus presented itself when the knee was fully extended or fully flexed. Crepitus was also present at both ankles when circumducted. Crepitus was not identified at any other joints on the body. Due to my patients having had meningitis in the past, the neurological assessment is a system of high priority. Meningitis can cause long-term neurological damage if not treated properly. Additionally, my patient has had continued headaches which should be assessed. For this reason, I will be conducting a complete neurological assessment. Review of systems. Patient has had no history of stroke or paralysis. Patient has had no history of seizures or tremors. Patient has never experienced a head injury, concussion, dizziness, unexplained memory loss, or confusion. She has never had any trouble walking, talking, or swallowing due to her neurological condition. Patient reports that she has never had numbness, tingling, or weakness related to a neurological condition. Patient states that she has had migraines in the past, but she has been getting them less frequently since treating her meningitis. She claims she does get tension headaches a couple times a week related to stress. Patient usually sleeps or takes ibuprofen to relieve her headaches. Patient has had no history of neurological disorders. Her maternal grandfather has Alzheimer's. Physical assessment. Patient's general appearance is calm and relaxed and as expected. Patient is oriented to person, place, and time. Patient's facial expressions appear symmetric with no involuntary movements. Patient has an even pattern of speech without stutter or slur. Patient can respond to questions and directions. Patient has an intact short and long-term memory. Patient is capable of abstract thinking and could perform basic calculations. Patient's motor function was intact and gait was even and coordinated. Patient had no excessive swaying or loss of balance during the Romberg tests. Patient's fine motor skills were smooth and coordinated. Patient has adequate sensory function and is able to determine between heat, pain, and cold. Patient was able to sense vibration and determine between point of touch on the body. There was no sign of a Babinski reflex or ankylosing. Patient's reflexes were present and 2+ in all areas. Pertinent systems. According to a peer-reviewed research article written by Hans Petersen titled Long-Term Effects of Bacterial Meningitis in Childhood and Adolescence, there is thought to be a correlation between having meningitis at a young age and hearing or vision loss with aging. These problems can include diopia or astropia. Hearing problems stemming from bacterial meningitis may include tinnitus or hearing loss. Since my patient had meningitis in her adolescent years of life, the HEENT, or Head, Eyes, Ears, Nose, and Throat assessment, would be a critical assessment to perform and evaluate. Additionally, according to Dr. Michael Kroskoff in his article Exercise-Induced Bronchial Constriction, Diagnosis and Management, exercise-induced asthma is a very common problem that nearly 10% of the population has. It can cause chest tightness, wheezing, and fatigue. Although my patient's asthma is currently under control, it should be periodically reevaluated to ensure that symptoms are not continued despite interventions being taken, as this may indicate there are further underlying conditions. Therefore, the respiratory assessment should be a key assessment to do on my patient, in addition to the musculoskeletal, neurological, and HEENT assessments. This is the end of my presentation on my patient. Thank you.